And welcome back to the next phase of our discussions, which will be elaborating on a number of the points that we've already started to broach in that first conversation. And as we start this discussion of shared decision-making with Al and with Roberto, I'd like, first of all, to tell you a story, which was, I suppose, the first time I really started to think about this, when I heard the story in an entirely unsystematic way and then became fascinated by the whole area of shared decision-making. This is the story of a lady called Jean. She was an older lady. She was 86 years old, and she had a fall. And she actually broke her neck, 3 fractures in one of the vertebrae and in the odontoid peg. And she was in hospital, flat out on a trolley, and there were 2 orthopedic consultants discussing what to do. And it's one of those cases where the obvious treatment was conservative and was to be a collar to be worn for 3 months. But they wanted to be on the safe side. So what they decided to do was to consult the neurosurgeons at a neighboring hospital. And in one sense, this is an admirable example of the exercise of a right, because they were concerned that Jean should be able to exercise the right to the best available care. And importantly, of course, this was not to be discriminatory in terms of age, because there is that tendency, of course, as you deal with older patients, to think that they should not have certain treatments. So in that sense, you could see that there was, as it were, a rights-based approach. The interesting thing about what was going on in that consulting room was that neither of the consultants spoke to Jean. She was just flat on the trolley, and she had all her faculties, but she was not engaged in conversation about this. This was simply a decision that was taken. The consequences of that decision were 3 additional days in hospital waiting for the results to come back, 3 very distressing days, and the neurosurgeons, rather unsurprisingly, coming back with the statement that this should be a conservative treatment rather than an operation. And Jean was then sent home. But what was going on there? She wasn't actually party in this case to the exercise of her right. And if she had been, she would have chosen the conservative treatment, having had options and risks explained to her. And interestingly as well, that would have been 3 nights in a hospital bed that would have been saved for her, but also saved in terms of resources as well. But nobody had spoken to Jean. And that was something years ago that started me thinking about the nature of shared decision-making in an unsystematic way. And 2 people that are sitting here have thought about it in a very systematic way through their various experiences. And we're now going to have a conversation with Al, where we're going to be looking at some of the origins and some of the developments in shared decision-making, engaging patients. And then we're going to be talking to Roberto, looking at how this fits in more systematically and also how it brings in relationships with the state and with healthcare providers. So first of all, I'd like to ask Al to tell us a little bit more about, well, what exactly is shared decision-making? It's not merely informed consent, is it? It's not merely getting a patient to sign a paper. What's at the heart of it?
No, you're right. Shared decision-making is not simply informed consent, and it's certainly not the kind of care that Jean received. 2 clinicians were talking about Jean because they were highly trained, and they thought that the scientific knowledge base that they had, that she did not have, would give the right answer for Jean. And Jean wasn't in a position to make an informed choice and wasn't engaged in a way that would elicit her preferences. So shared decision-making could be characterized as a very intentional approach on the part of the clinician to engage the patient in making an informed decision that reflects not only the evidence about what options are available and what the likely outcomes are if one treatment as opposed to another is used, but also recognizes the patient's unique expertise in how she, in the case of Jean or others, feel about the different interventions and their consequences. So that's a simple expression of what shared decision-making is. It reflects the fact that often Patients are treated as if science gives you the right answer, when in fact there are two equally important fields of expertise that need to be brought to bear in order to make the right decision for an individual. One is the expertise of the clinician that comes from the science, and the other is the expertise of the patient, which comes from what gives meaning to life for them. And in many ways, shared decision-making is about the right to make the kinds of choices that determine your future.
Could you tell us a little bit more about the origins of the ideas of shared decision-making and how you became directly concerned and involved with it?
Well, first a little bit about my background so you can sort of unpack the biases that you will undoubtedly be exposed to in the next 15 minutes. I was an undergraduate at Dartmouth in the late 60s, right after the United States had passed their somewhat feeble attempt to achieve coverage with Medicare. And that was 1968, and I was a pre-medical student largely by default. I was first generation to college and didn't want to be a lawyer, so it was medicine. And I was exposed by some faculty members to a paper that was just published in Science in December of 1968 that I think is foundational for the conversation we're having. It was Garrett Hardin's Tragedy of the Commons. And it turned out to be a very controversial paper because it was a rather pessimistic view of how civil society, if you will, or communities can come together to intelligently govern common pool resources. And I remember reading that and thinking that there were going to be a lot of common pool resource questions related to Medicare, and that I would only go to university where I could not only get my medical degree, but get a degree in economics while I was studying medicine and not be viewed as subversive by the medical faculty. So I spent a lot of time learning about decision-making from economists and then tried to apply that in my work as a clinician. I didn't want to bring it into policy. I wanted to apply economic thinking to the way doctors and patients make decisions together. My first opportunity, afforded to me by a common friend with Roberto, Alex Leaf, was to study intensive care. And we built a large database characterizing the interventions that we would deliver to patients when they were admitted to the intensive care unit, and then followed their outcomes. We followed them for 3 years. And one way to think about that is we were trying to narrow the confidence intervals around the probabilities of good and bad things happening to people when subjected to intensive care. But I was also an intensive care clinician, attending physician at Massachusetts General Hospital. So I was engaged in working with interns and residents in training in making the kinds of decisions that are fateful, often end-of-life decisions in the intensive care unit. And there was one day when I had an epiphany about this, and I was walking back to my office after helping a patient and family make a very difficult decision about whether intensive care should be continued for this woman. And there was a decision to be made because she had, the doctors in the room will know immediately what I'm talking about. She had been intubated nasotracheally when she came in. It was very unlikely that she was going to survive, but she'd had the nasotracheal tube in for 11 days, and you can only keep it in for 12. So the question was, do we do surgery to continue this potentially life-saving care, but with a very, very low probability of success? And I remember walking back to my office feeling good about the conversation and thinking about what I'd learned from economists and thinking that, well, this decision was not sensitive to the research that I'm doing. I can spend the rest of my life narrowing confidence intervals, and for this woman and her family, it didn't matter whether the probability of survival was 1 in 50, 1 in 500, 1 in 5,000. What really mattered was how she and her loved ones felt about how, where, and when she was going to die. And that was not a matter of scientific evidence, because she might feel very differently than the woman in the room across the hall. So my research was being published at this time, and I was asked to be a consultant for President Carter's Commission on Bioethics in Medicine. And that was the first time I heard the word shared decision-making, so I am answering your question. And my interpretation of shared decision-making, I didn't coin the term, but my interpretation was it's really important to get the probabilities right. And that's where the science comes in. But to use the language of an economist, and I know there are many in the room, you also have to recognize that different patients have different risk attitudes. They make different time trade-offs. Some people live for the moment, some people live for the future. Economists call that a discount rate. And they also have different utilities for exactly the same states. And there are lots of examples of this. So from my point of view, shared decision-making was about being sure that the patient understood the options, the therapeutic options, and what their outcomes were likely to be, and be as precise as you could about the probabilities. But let's also be sure that we work to engage them and elicit their expertise about what matters to them. And again, to use the economic vocabulary, their utilities, risk attitudes, and discount rates. So the extrapolation of that, that was 1982, when I was walking back to my office and had this epiphany. And just about a month later, Jack Wenberg's first clinical article was published in the New England Journal of Medicine. And it replicated evidence that he had demonstrated before in the state of Vermont in 3 countries, the US, the UK, and Norway. And what Jack had discovered when he went to Vermont in the late 1960s, Jack is a famous colleague. He's probably the most famous health services researcher in the United States, for sure. He had gone from Johns Hopkins to northern Vermont to advocate for greater health services for the poor people who lived in rural Vermont. He was convinced that there weren't enough hospital beds, there weren't enough doctors. So he created a methodology to study the epidemiology of healthcare, not the epidemiology of disease, the epidemiology of healthcare. And what he found was he was wrong. The people in northern Vermont did just fine. But what stunned him was that in different hospital market areas, people received dramatically different care. The rate of tonsillectomy among adolescents varied 17-fold. Hysterectomy, 6-fold, 600% difference in one hospital market area as opposed to another. Prostatectomy, 4-fold. So the ethical issue there instantly recognized is that the care you get depends more on where you live and who you see than who you are and what you care about. In a country that has plenty of wealth to provide services on an equitable basis. And there are enormous economic implications as well, right? It's a lot more expensive to do a tonsillectomy than to not, to do a hysterectomy than to not. So I went up and when he replicated this with Clem McPherson in the UK and with Eric Hovind in Norway, I went up and I pointed out to him that you're focusing on the professional uncertainty as the explanation for this kind of variation from one region to another. But be careful, because that suggests that all the variation is bad. And we just have to have organizations like NICE developing guidelines to tell us what we should do. But that ignores what we call the warranted variation that reflects differences among patients in what they care about. So my argument was, be careful if you just focus on the uncertainty and suggest that that's the problem. We will have guideline-driven healthcare everywhere. And with guideline-driven healthcare, you give interventions to people who wouldn't choose them, while you withhold the same interventions from people who would.
Now, what you're describing, Al, is in one sense highly complicated and depends on a good assessment of evidence, but another is almost obvious that this is the right thing to do, and the evidence piles up behind it. And what you're describing is a journey that for you began 30 years ago. It was a journey that actually began for others before then in terms of the evidence being available. Why is it so difficult? Why is it so problematic to adopt this approach of shared decision-making?
Well, remember the 2 orthopedic surgeons standing over Gene. They had strong reason to want to believe that their scientific training empowered them with being able to come up with the right answer. And to effectively deliver the treatment. Not only do doctors have a reason to want to believe that all that they've invested in their education and training empowers them to come up with the right answer and execute effectively, patients have strong reasons to want to believe that as well. you mentioned in the earlier session the importance of recognizing that decision-making confers responsibility, and sometimes that responsibility is very difficult when you are feeling vulnerable. When you recognize that whatever choice you make, there may well be a bad outcome. And instinctively, people know that bad outcomes feel worse when they feel responsible for the decision that preceded it. That's called regret theory among behavioral economists and cognitive psychologists. So doctors want to believe that science mediated by them gives you the right answer well executed. Patients want to believe that science mediated by them, by doctors, gives you the right answer. They don't want to feel vulnerable and unable to trust somebody. And policymakers too, use this notion that science mediated by the trustworthy people who got through organic chemistry and beyond gives you the right answer to shield themselves from the political costs of being seen as withholding moral entitlements, which is a big part of what we're talking about here. So there's this kind of dysfunctional equilibrium with everybody talking about healthcare as if science gives you the answers. When in fact, if you just probe a little bit, people recognize, I don't want to be treated like the average patient. I want to be treated like an individual who makes choices that determines what the future is like for me and what gives it meaning.
Thank you. And how would you say that this, or could you elaborate on how this is essential to a rights-based approach?
Well, we can go somewhat deep on this. I'd like to come back and talk about the economic consequences, but let me first say that Leo mentioned Amartya Sen's work yesterday briefly. And to me, the very simple paraphrase of development as freedom is that development economists have to recognize that income isn't a good in and of itself. Income is an instrumental good. Income is a good because it gives you the freedom to make choices that matter. It unburdens you of unfreedoms, I think is the language that he uses. Well, healthcare is the same. Healthcare is not a good thing in and of itself. I will often say to people to get to appreciate this and also to get them to understand a different way of thinking about complexity in healthcare, Joe, is that if I could guarantee you all that tomorrow at noon you will be at the top of your game, physically, intellectually, emotionally, spiritually, with or without 12 hours in the nearby hospital emergency room overnight, which would you choose, with or without? I don't know anybody who would say with all that poking and prodding by strangers, right? And then I switch and I say, and if it were my sad but solemn responsibility to tell you that you or a loved one would not be with us in 30 days, guaranteed, 30 days, not 29, not 31, 30 days. Would you want to spend those 30 days in the intensive care unit where I used to work, or would you want to spend it doing some things and being with loved ones with peace at the last at the end? Again, no one chooses the intensive care unit, right? But then I have to acknowledge that I've cheated in two ways. I pretend that I could give you a guarantee. Top of your game, dead. And there's too much uncertainty in life, and all of that uncertainty applies dramatically in healthcare. And in addition, I've chosen top of your game, physically, emotionally, intellectually, spiritually, and dead, right? Those are two extremes. And there's a lot in between. And virtually everything in between involves trade-offs. And it's in the trade-offs where the individual differences, the individual wants and needs really matter.
There's an element here, though, isn't there, that if one talks about shared decision-making with people, there are quite a few people, not just physicians, as it were, but people who would be patients who shy away from it because they think it's going to be really hard. They think the decisions that they're going to be taking are things they can't themselves take. They don't want to take the decisions. They're too scary. Could you react a little bit to that?
Well, a big part of that is what I was referring to as anticipated regret. They instinctively know that bad outcomes will feel worse if you feel responsible for the decision that preceded it, so they're trying to put the decision off. We've recently tried to address this in a new way. We've reframed. We wrote a monograph recently in the UK about practice variation, which I described as part of the origins of shared decision making. about shared decision-making as the response to practice variation, and about its implications for commissioning in the NHS. And we chose to not use the phrase shared decision-making because we've been trying for 30 years to get people to embrace shared decision-making, and they all think it's just some fluffy being nice to patients for the most part, right? And patients often think that too. So what we call this paper was Patient Preferences Matter, Stop the Silent Misdiagnosis. So we were trying to surface this is a significant problem. And by silent misdiagnosis, we mean that in this day and age, the doctor's job is only half done when he diagnoses the disease. In the old days, that was usually all he or she needed to do. You diagnose the disease, and it's if-then. If this disease, then this treatment. If you're lucky, there might be one treatment, right? Now we have so many treatments, we were talking about that yesterday, that there are lots of choices, and these treatments have different side effects. Think about mental illness. Think about the 5 psychotropic drugs. They're all roughly equally effective, but they have dramatically different side effect profiles, right? So which side effect profile would you like to live with? Which side effect profile would you like to live with is a really important issue. So what we did in this was to point out that there's all kinds of evidence to suggest that doctors don't diagnose patients' preferences. They're not aware of the need to do so. The patients aren't aware of the need to do so. And the way it comes around to commissioning, is that the problem with healthcare, the problem with all of the systems we're talking about, is that whatever capacity you build in a healthcare system, you can be almost sure it's going to be used. Markets fail in healthcare because of the asymmetry of information and the degree of difficulty in getting out of the market once you've invested to get in. Planned economies fail in healthcare for the reason I described, with this tension between populations and individuals, and giving interventions to people who wouldn't choose them while you withhold them from people who would. Right? You have to recognize those two sources of failure and turn science from a focus on the natural sciences to include the subjective stuff that matters so much to patients, and create a science of patients' preferences. Because if you've got informed patients, informed community members, and this goes back to Alma Ata, if you've got informed community members and informed patients recognizing the right and the duty to be involved in the design and implementation of their health care, the most precious information to those who are building different capacities to deliver different services is the revealed preferences of patients who make informed choices. It's the essential information. You know, for 20 years, the NHS has been trying to figure out what an internal market means and what commissioning means, and most people in the UK would acknowledge it hasn't worked. And that's because they haven't had the essential data. If you build capacity in healthcare without revealed preferences or accurate measures of the needs and wants of individuals, you will fall short of meeting the needs on a regular basis while you're exceeding the wants in other areas, distorting the care that individuals receive. And that's what creates the 20 to 40% of waste in healthcare systems across the range of wealth of nations.
That's, I think, an extraordinarily powerful idea, addressing the individual and individual preferences and then aggregating that to inform how you develop health systems and how you develop capacity.
What you invest in.
Yeah. Mm-hmm. Now, the importance of economics is clear, and we're going to turn to Roberto as a health economist now. One thing that was once said to me, which made me think, was a friend who is both an economist and, incidentally, an atheist. What he said was that economics is merely a branch of theology. Needless to say, I had to ask him to explain this particular point. And his argument was that both economists and theologians have a tendency to believe in something that doesn't exist. Being an atheist, he had that view of theology. Being an economist, he had that view of homo economicus. That is, the perfectly informed individual who makes perfectly rational choices. Now, Roberto, in this context, does not believe in homo economicus, that perfectly informed individual making perfectly rational choices. And indeed, I was talking last night with Roberto about this whole topic, and he was explaining to me the work of Kenneth Arrow, who has looked at the way in which Homo economicus does not work, particularly in healthcare. You've got this asymmetry of information. Al has already mentioned that. That is that the consumer, the patient, simply doesn't have the necessary information and thinks, perhaps, that they can't have access to that information to be party to a decision. So it's all put over towards the physician. Also, Arrow points out that, of course, generally in these circumstances, the patient is ill. That is, their capacity to be engaged is something that is not so immediately obvious because of that illness. Now, this is developed, Roberto was explaining, into something called principal-agent theory, the way in which the patient actually pushes the responsibility and it is received by the physician for making the decisions. So that what you've got is that asymmetry is resolved in that sort of deal between the two, the physician becoming the principal agent. This also involves a great deal of trust between the two. Now, the first question I want to ask Roberto is first of all to correct that summary gleaned in the Meyerhoff Cafe last night, and also to elaborate a little bit on it, first of all, with regard to, as it were, the individual contract, yes. And then we'll talk a little bit later on the aggregates.
Okay. Thank you. I think you're right. What we economists notice or try to describe is that individuals, there are circumstances, not only in health, but in many other circumstances, where individuals delegate to someone else a decision-making power. And in the case of health, given the asymmetry of information, when you go to bring your car to a mechanic, right? It's a similar situation. You bring your car and you give it to him. You don't know anything about mechanics or engines or whatever, and you trust that this mechanic is going to open the car and is going to look at it and say, oh, you need to change X, Y, and Z, and you trust him, and hopefully that's going to work. It's a similar way with physicians. You give him your body and hope that they will give you the right advice. What Al is saying with the shared decision-making process is that what the shared decision-making process is trying to do is trying to minimize or mitigate the main problem of the principal agent, which is the asymmetry of information. What is he saying? Okay, I'm going to share with you, the physician is saying, I'm going to share with you the information that I have. What are the prospects, whatever, and we're going to make this common decision here. And what is expected is that the outcome of that decision-making process is going to be a better one, right? That it's going to respect the science, the knowledge, and the individual utilities and values and so forth. So I think the shared decision-making framework brings a lot to solving, or not solving, well, there is an issue that we can talk about a little later about the ethical problems and in the case of the social contract when you talk about populations. But that minimizing some of the problems that the principal agency that generates, right?
Can I just ask if Kenneth Arrow were with us here and he just heard Al and what you've just said, do you think he would be convinced that shared decision-making, that they could have a redress of this asymmetry? Or would he have any reservations?
I think he would have reservations because it doesn't solve one problem, which is the ethical posture of the physician or the decision-maker. It does minimize the problem in terms of information, the asymmetry of information, whatever, but it doesn't solve the issue of whether the physician has or the mechanic has a vested interest in providing something because it pays more, because it's related to a research that the person is doing, and so I have an interest in giving you that direction because I want to learn what that track might bring in terms of. So there is that background that's still there. We're human beings after all. That needs to be minimized. But of course, the more information you put out there, the less likely is that you're going to be able to overcome a person because you're his or her agent, right? So even the ethical issues might be minimized that way, but obviously it doesn't solve everything.
Right, thank you very much. We're going to talk about how this affects citizens and their relationship to government, but first, Al, do you have any comment on that?
I think in complex systems, complex adaptive systems, it's good to have some simple rules that everyone will agree with. And what I was describing earlier, the ways in which I cheated, that there's uncertainty in healthcare that people don't want to acknowledge because it's scary. And there's this disagreement about what matters that people don't want to acknowledge because it's scary to think that they need to engage in the decision. That creates a kind of fog of healthcare. And one way to cut through that fog is to come up with these simple rules and to say that the goal is to give people the care they need and no less than the care they want and no more, and those are equally important. Okay, because we've got these common pool resource problems. The last thing we want to do is to give expensive care that people would not want if we could simply avoid the ignorance under which the decision is being made. Right? So that leads to the second simple rule, which is the boundary. We don't let people make fateful decisions in the face of avoidable ignorance. And then what is it that we want to reward in our health systems? I would argue that we want to reward this personalization that I'm talking about. We want to reward accurate diagnosis of preferences. And if we were able to do that, if we were able to say, and just as an example, does anyone in the room disagree with any of those simple rules? The goal is care they need and no less, want and no more. We avoid avoidable ignorance, and we treat people like individuals in a personal and compassionate way. They're kind of ironclad simple rules in sort of the political domain. And if we did do that, it would create this circle of new information about where we should invest in capacity to deliver different services.
I just say, and I think this very necessarily needs to be parked for later discussion, but there is a philosophical issue here. For instance, the philosopher Derek Parfit discusses this about the relationship between an individual now and their future self. And this is in itself problematic. That we tend to treat the individual as someone who is fully determined as of now and for themselves in the future. That's not necessarily the case, but I fear we'll get into rather muddy and complex waters if we pursue that now.
Let me turn back to Roberto, but I'll make a very brief comment. An important part of what shared decision making is about, and the early programs we developed, I didn't mention, the early programs we developed surprised us in that when we did give people information and did help them accurately imagine the alternative futures they would live with. That is one way of expressing the goal of shared decision making. You can't control the future, none of us can. You certainly can't control it with regard to your health. But the decisions you make today will have a very strong influence on the health futures that you live with. And how can you help people accurately imagine the alternative health futures? That's all about engagement of patients, engagement of community. How do you get them to recognize the implications of being vaccinated or not for themselves and the community? How do you help them accurately imagine those alternative health futures? So there is
more of that perhaps in the future. And Roberto, could I just ask you to talk a little bit about how this applies to the citizen and the state?
Okay.
How do we look at it on the sort of the larger conspectus?
Yes. And this is something that I would like to pose to all of us. I think we can transfer or translate the idea of the principal agency that we talked about on the patient-physician relationship to the relationship with the citizen and the state. We can think of citizens transferring to the state or delegating to the state the power to take certain decisions and make certain investments, expenditures, and whatever, to fulfill certain things, like justice, like protecting public health, like safety, And we can think of also that in terms of the right to health or rights, right? We as citizens have given the state and its powers, the executive, the legislative, and the judicial power, as we can think of them as agents that are there to ensure that our rights are fulfilled. So when we think of the government, the executive power, we've given them the power to implement health services, deliver goods, and purchase and contract physicians and other workers to provide care to us. As agents, this executive power may work well or not. They are good agents or bad agents, right? Because of several reasons. So we have to have means to make that agent work better if that's the case, right? Similarly, we as citizens have given the legislative power to promulgate laws and that protect us from harm, that ensure accessibility, availability, and appropriateness of services. So we hope that that regulatory framework is out there and it works well. It may not work as well. And we as citizens have given the judicial power the mandate to enforce if the others are not, particularly the executive power, if it is not working well, to mandate them to improve or deliver our right to health. I think Margot said here before, and I tend to somewhat disagree with that, is that the judicial power has an important role in that sense because it's one of our agents that is out there to enforce our rights, right? Whether that judicial power also works as a good agent or not, we can discuss. And how far should it go, this is another issue. And then we go back to the point that in the same way that in the patient-doctor relationship, there is an ethical principle and ethical values behind that relationship, between the citizens and governments and the state, there is a social contract behind that. That social contract can be expressed in the constitutions, in laws, but not everything is reflected in the books, right? There are general views of how society views themselves. I'll give you an example. The US, for instance, is a society which the social contract is very individualistic. I mean, for some of us, for me, Brazilian or Latin American or whatever, it's hard to imagine that people are willing to, not accept that, 40 million people are not insured and whatever in a country like that. I mean, it's their choice. Okay, it's hard, but there is a social contract in that country that operates in some way. That is very different from the one that operates in Brazil, for instance. When I got back to Brazil after graduate school, I was teaching at a school of public health. Imagine an economist coming back from graduate school thinking that he knows a lot, and talking to physicians and public health officials and saying, oh, there's not money for everything. You need rationing is unavoidable. They wanted to throw stones at me, But I was talking to these people, and I say, in Brazil is one country where the Constitution says the state is required to provide pretty much everything to everyone all the time. We know that's not feasible. Maria Luisa said that here, and we all know that's not feasible. And I was talking to my colleagues, and they say, it's fine. For me as an economist, it's hard to imagine, but they say, we know that we're not going to be able to deliver that. He said, no, it's fine, because it's important for a country as a social contract to have that utopia out there. Whether one accepts that or not, it's another discussion. But especially in a country like Brazil that was coming from a dictatorship and whatever, people view that as important part of the social contract. So these things are there for a reason, no? So I think that we can translate that idea of the principal agency to the relationship between citizens and state, right? And if I may, I think there is, in a similar way that the shared decision-making is important, what it brings is transparency to the relationship between the patient and the doctor, right? So we think of, we need transparency in the relationship between the citizens and the state, right? We talked a lot here about transparency. Transparency has lots of values. It's not a panacea. Nobody's saying that's going to solve all the problems, but it's an important element so we can understand how decisions are made, if the state is actually delivering on its promise to fulfilling the right to health. If we don't know, we don't have the basic information, then we cannot go very far in terms of addressing our rights and claiming our rights.
Oh, sorry, you wanted to?
Well, I was just going to say, when I found Roberto's analogy very interesting and compelling, and I just want to extend it a little bit. If you think of shared decision-making as the agent very intentionally trying to minimize the dependence of the principal on the expertise of the agent, and recognizing the expertise of the, in this case, patient or principal. The same applies to the kind of governments that most of us aspire to. We're talking about participation. We're talking about governments that are wise enough to minimize the dependence of the individual on the principal on the agent.
Absolutely.
So in a sense, you know, I've often thought of shared decision making and this notion of identifying individual preferences and then using the aggregate of the individual preferences to inform the investments in capacities within systems as a very scientific model for thinking about participatory democracy in building a healthcare system, which brings me back to that quote from Alma Ata about having a right and a duty to participate individually and collectively in the design and implementation of the health system.
Thank you, and thank you both, Roberto and Al, for that fascinating introduction.